A note as a segue from Cynthia, the work CQC have done is absolutely incredible. You might hear the occasional, and it is occasional, horror story on the television or whatever, but if you look at the volume of health and care provision in this country, through Cynthia's work, I think we will be in a much better place. And she has an impossible job, but I think it's real credit to somebody who actually really cares about people to take this forward. And I think that's a lesson for appointments to health and social care at a national level for the future. You need people who really care. This isn't just about numbers and about technology and things. This is about human beings. And as a segue into this then, this is the NHS Constitution. So the summary of my short talk will be what we need to do is get back to talking about humans, talking about the values and about what the NHS does, because the problems we've had in introducing the legislation have largely been there because we've forgotten what the NHS is there for. And the NHS does belong to all of us. It's the closest we have as a unifying religion in this country. And when you start to look at trying to change things, you have to really think really deeply at the beliefs and values of a system. It's very difficult to change the beliefs and the values. It's much easier to change the artifacts, the environment, the look of a building, or where care is provided, or whether it's a doctor or a nurse. But if you forget the values and the beliefs, and you forget to talk about those, it's very difficult to change anything. It is strange being in this building as well, which is, as you know, the Liberal Club, and was the Liberal Club until the sort of demise of the size of that party. So I thought I'd show a picture of their main competition in Victorian times, Disraeli. And it's just that health within the UK and within every country is such a key thing. It's much more than doctors providing health care. This is about the health of people. It goes back to nutrition, to the economy, to drains. And my other role is as champion, as chair of the Health Inclusion Board for the homeless, for sex workers, for gypsies, travellers, learning disabilities, people who are on the margins of society. And I want to start by saying it is a disgrace that within 3 miles of where you're sitting at the moment, the average age of death of the homeless is 40 years and 3 months in the 21st century. So if you're proud of healthcare in this country, you just think of those who are excluded. Think of the institutional racism for gypsies and travellers. And then for those of you who've stood up and said, kill the bill, the NHS is wonderful. Just remember, it isn't wonderful for every one of our citizens, and together we have to do better. And part of the theme of this is about politics and how politics changes. And the first coalition paper of the Liberals and the Tories was published in 1942, and it was voted against by the then Labour Party. And that was the Beveridge Report, which was trying to bring in a system looking at the caring of people. And it was followed by this paper, which was voted against by the Conservatives. So whether you think Labour owns the health service, or the Liberals own the health service, or the Tories, it's all of us that owns the NHS. It should be, as we all say, the National Caring Service rather than a health service anyway. But for me, health is about health, social care. It's about the social determinants of health, and that's what we've got to rally round. And the time now is for healing. Fine having fights about the bill as it's going through Parliament, but actually human beings are more important than a pile of paper, which is the Act or the bill. And now's the time where all politicians need to rally behind the NHS and make it a better place and recognise it isn't perfect, and we have to move forward. And so the story starts for me with Alan Johnson and Aradarzi. It actually starts one step behind that with Alan Milburn and the introduction of more choice into the NHS, what some people call the market into the NHS, which wasn't an invention of Andrew Lansley. It actually had been coming along in a less regulated way for a few years before. And I think what Alan Johnson and Aradati will be remembered for are two things. The first is putting quality at the centre of everything we do, which feeds into what Cynthia has been doing. That wasn't something we talked about overtly. It wasn't something they dreamt up. It was actually coming from the United States with their work on the quality chasm and other areas from there, and it came into this country. But the second thing is the NHS Constitution. This is a codifying or codex for the NHS. And I think if the Tory party had remembered the Constitution right at the start and talked about the basic principles of the NHS, a lot of the arguments, particularly in the social media, about trying to bring in co-payments, trying to bring in the free market, would have been easier to answer, and fewer people would have been frightened. And this was Andy Burnham actually launched this, as you'll see behind me, and as a junior minister wants to take credit for inventing it. I'm sure he did. Alan Johnson also wants to take credit. I don't care, really. This is something for all of us. But the principles are around the NHS providing a comprehensive service available to all. And then it goes on to say, irrespective of gender, race, disability, age, etc. You tell me if we've got age discrimination in this country. We need to sort that out. So even though we might have the wonderful NHS, there is still discrimination. And if you don't want to talk about travellers as a small group, think of the elderly. Access is based on clinical need, not an individual's ability to pay, aspires to high standards of excellence and professionalism, etc., etc. And that is the most important document, actually, not the bill. Andrew Lansley then came in to power with David Cameron and the others, and he had a vision. And that vision was, we talked about when I took over leading the Royal College of GPs many years ago now, and that vision has seen through the bill, and most of the arguments haven't been about the vision, it's been about the detail. And if you want to change anything, then you have to go back and think through some of the literature, and lots of people quote Machiavelli for all sorts of reasons, but actually it's change which is difficult and dangerous. And if you want to change the order of anything, then you're going to have trouble. And if you try to change based on people feeling threatened about the basic beliefs and values, then it's extremely difficult. Of course, the vision came in, but so did the Nicholson Challenge, trying to find this £20 billion to reinvest in the NHS over the 5 years. And by the time that Andrew launched his bill, people were very concerned that the finance was going to be difficult to deliver the changes that he was looking at. But when the bill went into Parliament, there were very few amendments in the first stage in the Commons. But as time went through, the Liberal Party, as you know, got very excited in Sheffield at their spring conference. And professional groups were getting more and more concerned about how the bill was written in detail, particularly about the regulation of care, healthcare, and monitors' role at promoting competition. But if we need to go back to how the white paper was originally written, because when we started doing our Future Forum work, we spoke to, at the end, almost 20,000 people. We spoke to all of the major organisations and the unions. Very, very few, handfuls of people, really could challenge or wanted to challenge the basic beliefs behind the bill. The NHS Constitution, as we said, patient-led NHS was policy of many governments over the years, delivering better health outcomes. People quote the Commonwealth Institute as evidence, but that is a series of surveys and comparisons with other systems. But if you look at the outcomes in this country, we've been brilliant at getting people treated within 18 weeks, but our one-year cancer survival isn't as good as it could be, and there are other areas. Charles, right at the start, talked about having a stroke in London. We still haven't got joined-up services across the whole country, and we can do better. And successive governments have said that they want clinicians to lead. Most people agree that public health is not just public health physicians, although they have concerns about where their jobs are and the pay and conditions. It's actually about the public's health, sport and culture if you're a counsellor, transport. It's about health prevention in its broadest sense. It's about education as well as the health protection issues and the things from public health. And as we heard earlier on from Cynthia, the next big change needs to be to implement a version of DILNOT, because until we've sorted out the funding of social care, it's very, very difficult to move together with health and social care, because there is always going to be mutual suspicion of if social care funding gets cut, and then healthcare will have to subsidise it. So with all that going on, people were rather pleased with what was happening generally in that first phase. And one of the highlights was talking about the outcomes and trying to move the NHS from 4-hour waits in A&E, from 18-week waits, to actually starting to look at the health outcomes, because Labour had done a brilliant job at getting some of the waits down, which is what lots of patients really demand and want. But now we've got to start to look at better clinical outcomes. And as you know, the National Commissioning Board will be organised around these 5 national outcome goals, with the top 3 being the responsibility of the medical director, Bruce Keogh, and the bottom 2 being the responsibility of the new chief nurse, Jane Cummings, who's another wonderful, caring person that's been appointed. And the thing that people also forget is, for the first time, the Secretary of State has a responsibility for addressing health inequalities all the way down the system. Because whilst we might have started to provide brilliant care, and some of our surgeries, some of our medical outcomes are better than anywhere else in the world, we still have a widening health inequality gap. And the most socially excluded really depends on where you live or don't live or stay, the quality of care you get, and we need to do better on that. But because of all the social and political and medical concern, for some reason, I think because I was not doing very much at the time and was expendable, was asked to lead the Future Forum on a Tuesday to get a team of 43 people together within a week, many of whom were away on holiday. And so we had all the politics of who was going to be on the forum. There was no political interference whatsoever, which I actually wanted in a way, because I was up for the fight at the time, but nothing happened. And we went around the country, met with lots and lots of people, and looked at these areas. And you can read our reports, but I believe we've had a massive impact on the writing of the bill, now the Act. So, for example, in choice and competition, when we met and talked with the third sector, they were very keen to be able to get more involved in the provision of care, actually, and in the design of care. And when you look at how Macmillan and Marie Curie have helped deliver, in partnership with the NHS, brilliant care for people who are dying, or if you look at WizKids providing wheelchairs within a day, better wheelchairs within a day, that I can remember as a GP, my patients taking almost a year to get an inferior wheelchair. When you look at competition, there's a need for it. But what we did was change the bill so that Monitor, and you have to have a regulator of the system, would be promoting cooperation and integration, but making sure we had competition if it was needed. We believe that we can then move to a much more integrated health system. Remember, competition under the previous government was not regulated like that, and in fact many of the independent treatment centres were given large amounts of money, and some of them did very little or no clinical care for that money. So this was trying to take the principles of having competition and making it work. And we said a lot about clinical leadership and other areas, as you can read through. We went around the country, we had lots of time to talk to politicians, but most importantly we spoke to many thousands of people in writing our reports. And to show the seriousness of this, the government gave up a lot of their time to work on this. And when we wrote our report on the Monday, we handed it over formally to the Prime Minister, Deputy Prime Minister, and the Chancellor. And on the Tuesday morning, they gave up the whole morning of their normal cabinet meeting just to talk about health and social care, of which myself and our team leaders went in and were interrogated and questioned by every single member of cabinet about health and social care and funding and how things are going and how things were for that morning. And one day I'll publish the questions because they're intriguing, but very, very helpful. As a result of that, we were asked to do a second phase of work, which was to look at how we can create a more integrated health and social care system. My belief is we should have health and social care fully integrated in time with more local democracy and more local decision making. The other outcomes were patients should feel they own their record, and that should pass between health and social care with all of the important issues of confidentiality. And we asked Fiona Caldecott to do a second review looking at the ethics and the behaviours and beliefs. But we also said that education and training, that system needed reforming, and every time a health or social care person had a contact with a patient or a client, they should take the opportunity to help improve health behaviours, shifting the health service to a more preventative and caring system. And I am going to stop in a second, I promise you, but some of the things which you won't read because they're not in the bill, I believe are really, really important. And I spent quite a bit of time talking to patients in Stafford and elsewhere about their experiences. In this country, we have some nursing schools at universities who don't interview for their students when they go in, so they can't even role play being a caring and compassionate nurse, and one medical school was the same. We've got to get our health and social care system back on the basics, the values of the NHS. We have to have a system which cares for individuals, with the individual at the centre of everything we do, treating people with dignity and caring and with compassion. And that means whether you're a social worker or a consultant cardiac surgeon, the professionalism that's in those roles has to shine through in treating people as individuals. And we've just started to do our third piece of work, which is reviewing the NHS Constitution, which is a legal obligation on the Secretary of State, and he has to do that by July, and we're doing it for him. But after July, we'll be wanting to come out and consult on how we can strengthen the Constitution. Because when people say the new NHS is going to be more fragmented, when you meet people on the ground, it's bloody fragmented now. People actually don't understand where they are in the health and social care system. When they say there's going to be co-payments and a postcode lottery, the NHS Constitution clearly says it's a right of any patient in England to receive a NICE approved treatment or programme. Well, that protects them against that. So my summary is, if we'd have started, or if the politicians had started right at the start and acknowledged that this was a continuation of policies that had been there before, that the NHS's values and principles were not going to be challenged but were going to be strengthened, I believe we would have had a much better adult debate rather than the hysteria that's been going on in the last few months. Whatever your politics, the time now is to rally together for the good of our patients, for the good of our clients, and produce a much better health and social care system that the homeless can be proud of, as well as the rich in Epsom. Thank you very much.
Thank you very much, Stephen, in particular for doing what I think is the right thing, to remind us of the values and beliefs of the National Health Service, and what is obvious, and I often think it's worth stating the obvious, that it is about the people that it serves, which is what we're here to discuss. So we now have the opportunity for some questions, and David, could I ask you to come and join us on the panel? So we've got Cynthia, Steve, we've got David from WRVS, and we've also got John Jolly from the Blenheim Community Drugs Project. So we've got about 10 minutes for questions and answers, and I'm going to invite anybody who'd like to ask a question to indicate, and if you could keep them brief, that would be great. So we'll start at the front here and take a few questions.
Thank you. Carl Freeman, Policy Manager with Guide Dogs. This is a question for anybody, really. The aspiration to have a fully integrated NHS and social care system is something I think we'd all support. I still think we're left with the huge problem of having local authorities working to radically different eligibility criteria, ever tightening, so perhaps they're becoming more similar. And no indication from a recent case in the Supreme Court.
Can we know what your question is, Carl?
Yeah.
Thank you.
How are you going to get round having a universal system where everybody can have access to health and social care, where social care is still subject to eligibility criteria?
Thank you very much. Gentleman there, a few rows back.
Thank you. David Wellborn from the Cass Business School. We've spent the last year...
I'm going to ask people to focus on the questions.
Yeah.
The reason is when we get to the workshops, there's plenty of a chance for discussion. So
that's okay. The last year's we've talked about completely the wrong things. How do we rebuild from now the story exactly as Steve has presented it? How do we overcome all those barriers and animosity that's being created by the wrong debate?
Thank you very much. If you could go back, Jay, to the gentleman there.
Excuse me, if you just give me, it's a comment. I'm outsider to this meeting.
Could we have your name and organisation?
Yes, I'm Ali Al-Shehri. I'm the president of Saudi Association of Public Health. I just come from Heathrow Airport straight to this prestigious conference. And I don't have a question, but I think it's been...
Then you will have to make an extremely brief comment.
No, but this is important because I think in the midst of this debate about the British system, I think I ask colleagues here and experts that to acknowledge that they have something to offer to other international healthcare system. Particularly, I'm talking about Saudi Arabia, not because only I'm a member and I follow the Royal College of GPs and public health, but also I think the NHS is close to my heart and it has a lot to offer to the other countries' healthcare system. So it's an opportunity for me to learn and network. Thank you.
Thank you very much. And I have to ask that gentleman there. Thank you.
Thanks. My name's Steve Caffrey. I'm from Milton Keynes. My question is, does the panel envisage a day, or specific members of the panel, envisage a day when there will be integrated health and social care electronic records?
A model question, thank you. And I'll just take one more there, the gentleman there. Thank you.
Hi, my name's Simon Patient, an independent nursing home operator. My question is to Cynthia, and it's a question and a plea, really. When or why does the independent regulator not give some guidance to councils as the cost of care for looking after somebody in a nursing home? And the background to this question is a lot of the non-compliance arises when the funding of looking after somebody falls very, very short of what it actually costs. And that's why we're currently seeing a wave of independent judicial reviews to try and take councils to book in court.
Thank you very much. And as it hasn't been covered, I just want to address a question to John, which I know a number of people are interested in, which is about how health and social care charities, like the one that John represents, what sort of challenges they're going to be facing over the next year or so. So if I can just go along the panel, and if there are questions directly specifically to you, could you address them? But if there are points in your area, if you could address them, I'd be grateful. So randomly, I will start with David and then move to Stephen along.
I'm just going to respond about the eligibility criteria because we've seen a tremendous amount of volume, rightly, of discussion about the Health and Social Care Bill. And what Steve was saying I thought was very, very interesting in terms of going back to first principles. But on the ground, we are seeing the most staggering shift in eligibility criteria and the most extraordinary impact on individuals, whether that's about provision of meals or provision of care. And yet I see almost nothing in the media about that. And it amazes me because somehow we're moving from a situation where all the debate is about the integration and the system components, and actually at council level, at local authority level, there's extraordinary changes going on, but no kind of repercussion and no public discussion. So I guess one of the things for me would be, you know, I think the health and wellbeing boards are actually a very interesting structure and potentially a very, very important structure. And I think the fact that we've got elected representatives as well as GPs, as well as members of the current structure, might just make some of those issues come to light and actually be the subject of local discussion as well as national discussion.
Thank you. Actually, I'll go to John next, if I may.
Okay, yeah, I mean, just picking up on the challenges for the voluntary sector and the social care network in terms of independent providers, there are some real challenges therefore, and I guess the biggest one actually at the top when I was asked, when the question came up was actually, well, actually number one is to actually survive. The second one is to adapt to the environment in which we're going in, and that's actually quite difficult at the moment, sort of sitting outside of the NHS or for any of us to actually look at actually what the system's going to look like and how's it going to fit. And I guess some of the issues around that, around localism, around the changes in the NHS commissioning structures. For us as an organisation, we provide drugs and alcohol support. That most of the funding for the drugs element of that is going into Public Health England, into an unring-fenced pot of money. It's half the pot of money in that pot, and it's not even on the top 4 priorities in London. So you can see that there's a level of concern that I would have about the impact of the changes that are going to have for my organisation. When you look at the way in which the changes are happening, market testing of elements of the NHS, what that means for us as an organisation, whether we compete, whether we're big enough. You look at localism agenda, but what does that really mean in big society? Because if you look at how procurement processes are actually happening, those favour larger organisations, and actually smaller organisations like ourselves actually are often prohibited from even bidding into those contracts because of our size. So those are some of the questions I have around that. In terms of the health and social care connections, I would say the key issue, if you want integrated health and social care, you commission an integrated health and social care system.
Thank you very much, John. Cynthia.
Okay, well, I will contribute to the Carl and others' questions about integration. To me, the centre of this will be about user power and how people can, whatever we do, whether it's through transparency in the publishing of information, whether it's about construction of choice, whether it's about information, whether it's about the behaviour of individual clinicians or service providers, whether it's how GPs take on their role in commissioning. I think central to this, to developing more integrated services, giving as much power and authority that we can to people who use services and supporting them to make choices about what's right for them, because that will drive integration in a way that we've never been able to do with the work we've done on commissioning. And I speak from somebody who spent years trying to work on this. The answer to the question of the gentleman over there, wherever he was, is that, you know, we are, in the true legal sense, we are not competent to make a statement to local authorities about what care should cost in a particular circumstances. So I cannot envisage us doing what you're asking us to do. But what I can say, and some of the information I gave in my presentation speaks to this, that instead of producing an annual state of care report, or just producing that, we're legally required to produce a state of care report every year to Parliament. We are determined, and we'll start doing this from April, to publish a quarterly update on the state of the market. And some of the information that I put up on the slides will feed into our first version of that. And in doing that, we will comment on what we're seeing of the market. So if we are seeing that it's changes in funding that's leading to huge pressure on the sectors, then we will make those statements through our quarterly state of care report. So that would be our intention. I think also when we conduct special reviews, for example, we've done around some of the hospitals where we've done investigations that have had severe problems, where we do see problems in commissioning services, we are allowed to make those statements. But for the rest of the time, we're focusing on the provider. But I think when we produce these state of care reports, where we do see providers coming increasingly under pressure because of the way services are commissioned, we will take that opportunity to say that in those general terms.
Cynthia, I've beamed in through text. It's very exciting. Proves it works. I've got a question for you, if I may.
Yes,
how do we ensure continuous improvement in standards of care in residential and own home environments without independent benchmarking and accreditation?
Well, I think that I don't see why we well, two things. First of all, I believe very strongly, and what I didn't do is do a sort of lesson on the 16 quality outcomes that CQC look at, because I imagine most of you are familiar with that. I passionately believe if every care provider in the country was always compliant with every one of those standards, we would see a massive improvement of in care. At that point, the legislation would enable CQC to raise the bar. We could produce guidance that raised the bar. But I believe very strongly as well that whether it's through things like the Royal College of GPs, through its independent star rating systems that exist in social care, that the industry should itself take responsibility for having separate independent accreditation systems. I think that's absolutely should be there. But in the meantime, with all the work we have to do, the regulator is focusing on legal standards.
Thank you, Cynthia. And last but not least, Steve.
Well, adding to that, we should be aiming for excellence rather than just mediocrity. I mean, you've got to have
Excuse me, my standards are not mediocrity, Professor Field.
Okay, break it up, break it up.
YouTube record.
But you know what I mean. You can get away with just being just above the bar.
Yes.
But safe. So safety is really, really important. But we want the best health and social care system in the world. We just don't want, sort of an average one. We want the best. And that's the role of professionals to take that forward. And that's where we need more vocal and stronger clinical leadership in my world from the colleges and others, really shouting out about standards, which is where they should be, rather than about legislation and the bill. But we've moved on from that now, I guess. The most important organisation, I think, with the changes is the Health and Wellbeing Board. And that's the one to get on and influence, because they're the ones who will have the role of looking across health and social care for the locality. It'll feed the JSNA and also be the body to challenge commissioning groups, challenge their own local authority, and challenge the National Commissioning Board. And that's why, personally, although it's not in the legislation, I believe there should be an independent chair of health and wellbeing boards so that they can challenge, even if they're part of the local authority. And certainly in Warwickshire, they've got a very strong independent chair called Brian Stoughton, who really is taking this extremely seriously. Integration really depends on human behaviours, and integration within a practice. Even if you're in a GP practice, how well do you integrate with your local district nursing or health visitor team? There are examples of brilliant practice. There are examples where it's appalling. And it tends to be human beings. Legislation should do two things. It should remove barriers to integration, and it should incentivise to help people do things together. So one of the problems we have at the moment is there are incentives in GP land called the QOF and other incentives about improving care. We've got sequins in hospital care, which is an incentive to improve that, which was under the last government. And we're going to have a quality premium as well. So there are all sorts of different incentives. What we've got to try and do is share the finance and share the incentives across the pathways between primary and secondary care and between health and social care. Because unless we shift where care is carried out for the vast majority of people, where they don't need a hospital bed, into the community, we're not going to deliver better quality care within the financial constraints that every government's going to have. And you can see brilliant work here in this city at UCL, where they have a really a holistic approach to the homeless. We know the homeless go in and out of hospitals 8 to 10 times more than anybody else. They tend to stay there and often are discharged homeless again to get them out of hospital. They're treated really badly in many places. Where at UCL, they have a multidisciplinary team, including housing, which descend on the patient to help them as soon as they touch the hospital. And financially, it saves a fortune and they get better holistic health and social care. So if you can do that at UCL, why can't you do it in other hospitals? And there are lots of other examples of providing better care actually and saving money downstream. Why shouldn't social care be incentivised financially for keeping people out of hospitals? We should share the budgets, but we do need to get through this deal not issue about how we sort social care. I know you want me to shut up, but I don't get the chance to talk to people very often. So
I find that hard to believe, actually, but okay. I'll move it on swiftly. Can I thank all of the panel? I think we've had a very rich session there, and thank you also for your contribution. But if you would join me in thanking our panel. Thank you.